This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to the Neurology podcast. This is Alison Christy, a pediatric neurologist in Portland, Oregon, and we're talking today about a new paper, Neuroimaging Findings in Children and Young Adults with Neurotoxicity After CAR T-Cell Therapy for B-Cell Malignancies with Jennifer McGuire. Welcome.
Thanks so much, Allie. I'm glad to be here.
So you created a huge imaging database of MRIs of kids and young adults who were receiving CAR T-cell therapy for B-cell cancers. Why did you do this?
Prior to this project, data on neurotoxicity-related neuroimaging findings post-CAR T-cells were really sparse. They were mostly case reports. There were 2 single-center smaller series. And there are a couple of reasons, I think, for this void, one of which is that most institutions don't have consistent prospective imaging protocols in place for these patients. And part of that is because when symptoms are transient and quickly resolve, they may not have the opportunity to image in the first place during the acute phase. Or conversely, if symptoms are very severe, patients might not be clinically stable to go to MRI. And so a lot of institutions didn't have set parameters for when they should take pictures, which means we don't have a ton of data here. There's also a little bit of data void because the numbers of children and young adults that are imaged at any given institution wasn't really large enough to characterize a full range of findings. And so we realized the only way we're really going to be able to start to do this well would be to pool our data and our expertise. And that's how this consortium, Carnival, was born. And for things that are rare in pediatrics in general, this is really what we need to do, pooling our data and our resources and working together to try and understand things better. So we know that what one institution is seeing is actually representative of what other institutions are seeing as we try to better understand the disease.
So how did this happen, this pooling?
We started with an existing multi-institution consortium that was organized through the National Cancer Institute. It's called the CAR Nation Consortium, like CAR for chimeric antigen receptor and nation. And the goal of this group is to quote unquote, advance the efforts of CAR T-cell therapy in children and young adults by bringing together expertise and experiences to optimize CAR T-cell associated outcomes. So this group was really a natural place to start. And we reached out to the members of this group and identified 5 different institutions that had a pretty significant number of patients and the logistical ability to contribute. And those institutions were mine, Children's Hospital of Philadelphia. We had Seattle Children's Hospital. We had St. Jude. We had National Cancer Institute. And we had Children's Hospital of LA. And so once we had these groups, we had several planning meetings with everybody, decided what we wanted to collect, logistically how we were going to do that. We made some data collection forms, and then we asked each institution to provide some basic clinical data on all of their patients that they included. And then each of us all uploaded de-identified MRIs directly onto a shared imaging platform. So then we could have study neuroradiologists review them all in mass rather than just one institution reviewing their own imaging.
So once you had this really big database, you looked at a very specific complication of therapy, immune effector cell-associated neurotoxicity syndrome, or ICANS. Why that population, and what did you find?
ICANS is a relatively common neurotoxicity syndrome that we see after CD19-directed CAR T-cell therapy. In fact, it affects, in some cases, up to half of kids that receive this. And it's a pretty characteristic clinical presentation. The classic is that people have encephalopathy, depressed level of consciousness, and often some language dysfunction. And it's really a little hard to say how much of that language dysfunction is that they're encephalopathic and how much are they actually actively aphasic. But those are the things that classically start off. And then less commonly, we see some more severe neurologic problems, including seizures or focal motor deficits, and in some cases, focal or generalized cerebral edema. And when this happens, it can be a really dramatic acute presentation. For a long time, neurologists weren't necessarily getting called about all of these patients because they're being managed by these out-of-this-world fantastic oncology team who manages a whole lot of different systemic complications on their own. But I think this is becoming more obviously a significant burden of symptoms within neurology. We have become more involved as a whole. And so the thing is, we don't really understand what the pathophysiologic process is for this yet, hopefully. And if we want to understand what it is, first we really need to comprehensively phenotype it. And part of that phenotyping is understanding what the imaging features are and how that relates to other biologic markers of this disease. So that's like the scientific rationale. But the other logistical rationale for doing this is we wanted to be able to provide clinicians with a rubric for when they have an MRI in the context of acute post-CART neurologic symptoms. We wanted to help them understand which MRI findings might actually represent ICANS versus which might be from something else. And if they have that foundation to say, yes, this looks like ICANS versus something else, that might help you curtail excessive diagnostic investigations or looking for other etiologies of their symptoms. So our hope was that this would help streamline the clinical care and reduce the need for additional diagnostic testings for these acutely ill, medically complicated patients.
You mentioned that the language is often affected, but you didn't see that the language centers are often affected on MRI. Do you have any thoughts about that?
One thing going into this that we were hoping for was that we would be able to say, aha, if you have this neuroradiographic finding, you have this clinical syndrome. And as it turns out, that really did not come to pass as we had initially hoped. And probably that's for a couple of reasons. Number one, the different phenotypes of ICANS, I listed those all off before: language dysfunction, encephalopathy, seizures, edema. We don't actually know that those are all the same pathophysiologic process happening. Or some of those things might happen for multiple different reasons, like seizures, for example, right? Like you can have a seizure related to cortical irritability in any particular area, and you might have cortical irritability from cortical edema or diffusion related changes or inflammation or all these sorts of different things. So we are not quite yet at the point for saying this clinical phenotype goes with this pattern, but I also think we could maybe do a slightly better job in our clinical phenotyping to understand that.
So what are your next steps for this project and this database?
There are multiple avenues we could go down. First, using the database, and now we have a platform that we could continue to expand the database with other cases and other institutions if they're interested in collaborating. We'd like to start looking at other methods of quantitative neuroimaging. Did some basic quantitative ADC analysis for this paper, trying to understand were there actually ADC-related changes in the white matter, in the thalamus, in the brainstem that we couldn't just see with the naked eye on a clinical read. So we'd like to see if there are other ways that we could get at that, like using other types of quantitative analysis. But this is inherently limited by the fact that the images are obtained at different institutions on different scanners with different parameters. So this is a little bit tricky, and we need to be thoughtful about how we do it, but there's room for thinking about this further. The second thing that we have the opportunity to do is getting a sense of how head CT and MRI findings may be compared. You know, when you have a kid that has a new focal deficit and they're not stable to go for an MRI for 45 minutes, but a quick head CT is okay, should we be reassured if we get that head CT and it looks normal, or should we not be reassured? Like, what is the correlation there? Is a head CT good enough to give us some sense of what's happening or not? That's a wide open question. And then third, we can really use this database as a launching site for more multi-site coordinated prospective imaging studies, like as I was alluding to earlier, linking serum and CSF immune phenotyping to the imaging findings. And I think this is where we really have an opportunity to see like how this can teach us more about broad ICANS pathophysiology. But I have to acknowledge this is hard, right? Like we can say, oh, we're going to prospectively image every single kid that gets CAR T cells. But out of the 800 total-ish that were infused at our combined institutions over this time period, only 36 actually had MRI findings in the kids that were imaged. And so like, perhaps what we need to do is not image every single person that gets infused, but perhaps we need to take kids that have actual ICANS symptoms and be more conscientious about imaging them at onset, at 3 days later, at 3 days after that, at resolution, and trying to better understand the trajectory so we can compare across kids.
So what do you think is the main takeaway from this paper for me as a non-neuro-oncologist, pediatric neurologist?
For one, pre-infusion and post-infusion imaging is helpful. and having neurologists get more involved in the clinical care of these patients so we can better clinically phenotype what we're seeing is super helpful. And doing those things are both going to help with our immediate clinical understanding of what's happening in a specific patient and like how much further evaluation do they need and how sick are they and what is this that we're seeing? Is there encephalopathy because they're seizing? Is there encephalopathy because they're delirious? Or is it really ICANS specific? But I also think that just having more involvement with neurology and getting more imaging data is going to help our bigger understanding of what ICANS is. So point number one is neurologists need to be more involved with these patients and helping in their care. And the other takeaway point, we haven't really mentioned this before, but if you see brainstem involvement on an MRI, I would pay really close attention to if they have any clinical signs or symptoms of spinal cord dysfunction. And I would have a very low threshold to image cords because there have been some recent reports of myelitis as an emerging ICANS phenotype that seems like it behaves a little bit differently from the other more classic ICANS phenotypes and has been harder to treat with more disability. So if we recognize it sooner, maybe we can more aggressively care for those kids.
So what were the imaging findings with ICANS?
So we really found 3 unique-ish patterns to the imaging findings in this population that we don't see in other children who are getting oncologic therapies for leukemia. So the first and the most prominent is that we saw some pretty characteristic white matter signal abnormalities in a number of these patients. And these are supratentorial, they're bilateral, they're symmetric T2 flare hyperintensities that involve the external capsules and the extreme capsules. So you almost get this like linear discrete double lines on either side. It's really unique looking finding. And this can also extend down into the corticospinal tracts and into the periatrial white matter. And that finding in particular is really associated with severe ICANS. So we were talking before that there really isn't a great, if you see this clinical syndrome, then you see this imaging finding. But what we did find is that the more severe the clinical phenotype, regardless of what the specific symptoms, the more likely we were to find imaging abnormalities. So that's number one, these unique, symmetric, linear white matter findings. The second thing that we saw a fair amount of were findings in the thalamus. And so these were also bilateral symmetric T2 and flare hyperintensities that had this like kind of expansile change that looked like it was a little bit of edema in the thalami. And a couple of patients also had restricted diffusion in there, but not all of them. And none of them were actually enhancing. So this was mostly T2 and flare changes. And then the third kind of characteristic finding that we saw were some brainstem signal abnormalities. And these were T2 flare hyperintensities involving the central tegmental tracts and the inferior olivary nuclei. That was the most common. Some of these patients also had some changes in the central pontine white matter and the inferior cerebellar peduncle. And some of them extended into the central medulla and down into the cervical cord. There was one patient in particular that had these brainstem findings and also had a diffuse longitudinally extensive transverse myelitis. Those are the 3 major things. And I will say many of the kids that had these had more than one of them. So it wasn't that you had the white matter phenotype or the thalamus phenotype or the brainstem phenotype. Many of these traveled together. And I would say the vast majority, particularly of the thalamus and brainstem patients, also had the white matter findings as well.
What do you think that's telling us about what's actually going on in ICANS?
I think we are going to need some future, more multimodal translational products trying to compare some of these imaging findings to CSF and serum biomarkers and more detailed clinical phenotyping to understand. These findings, I say they're unique to ICANS, but I mean that in that they are unique to this clinical population and this clinical scenario of ICANS. There are other disorders that can have thalamus findings or brainstem findings or white matter findings. So this isn't like this brand new, have never possibly seen a pattern like this before. It's just in this population and the other things we would be thinking about, like methotrexate-related toxicity or fludarabine-associated neurotoxicity, other common things in oncology patients. This is quite unique.
Thank you for listening to the Neurology podcast. If you want to learn more, Jen McGuire's paper is out in the October 7th, 2025 issue of Neurology, Neuroimaging Findings in Children and Young Adults with Neurotoxicity after CAR T-cell therapy for B-cell malignancies. Thank you so much for talking with me today.
Thanks so much, Allie. It's a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.